The June MEC Minute is going to be on mass gatherings. So why are we talking about this? Well, this is the season for mass gathering events. We've got festivals coming up. We have the July 4th fireworks coming up, and then there are all sorts of other local events that are happening in our areas. All EMS providers should have some knowledge and challenges of having these large events. And I think if you work an event, you need to have some idea of what you should consider before showing up for duty at the event. And if you're on duty and the event is in your area, what do you need to know? In other words, if you are an EMS provider who's working your usual job and there's an event in your coverage area or even in a mutual aid area, what do you need to know while you are on duty regarding that event? And sometimes because you may be called in to provide additional help and backup to this event. So let's start with 3 scenarios. And I want you to think about these scenarios, and we'll talk about them at the end. And I want you to think about, are they the same? So I'm not going to give you the answers now. I'm just going to throw you out the scenarios, and you think about considerations that need to be had as you prepare for these events, or if you were to be there as a care provider. It might also influence what you think if you're there as a participant in the event, just in terms of your own personal safety. So let's start off with the first event. It's a sporting event. It's a big rugby event. It's between 2 teams. It's a long-term rivalry. It's being sponsored by one of the local breweries, and they anticipate there are going to be 20,000 spectators. It's going to be in a local arena that's outside. It's general admission, meaning there are no assigned seats. So it's first come, first served sort of seating, and to top it off, beer is only 50 cents a glass. The second scenario is a revival that's going to be held out in the country, and it's being held at a local farm at the end of a dirt road. They anticipate there are going to be 10,000 participants coming in to see and participate in this revival, and it's actually going to be a 3-day event. So it's going to be there in mid-August, and people are going to be expected to stay on site during this event. And then finally, we're going to have the Tour of the Hills, which is going to be a Labor Day weekend bicycle event. It's 75 miles through 3 counties. They expect 1,000 riders will show up with their support personnel. And along the 75-mile route, there'll be 30,000 spectators. Most will be at the beginning and the ending of the event, but they'll be interspersed along the course of the event as well. So think about these 3 scenarios and how you might approach them, either as a participant or as a spectator or as an on-site EMS provider or as an EMS provider who is going to be on duty in the local community where this event is being held. So I think we need to start by what is the definition of a mass gathering. And I think one of the things we can say for sure is there's no fully agreed upon definition, but most definitions will vary, and they say use a threshold of anywhere from 1,000 to 25,000 spectators and participants. FEMA uses the word special events instead of mass gathering, and they define it as a non-routine activity within a community that brings together a large number of people. And if you look at their definition, there's no mention of a number or a critical number of participants, and the number of people is less important than how well can the community respond to the activity. So if you have 1,000 people participating in an event in a large city, that may be nothing to absorb, versus a small community where 1,000 people doubles or triples the population of the community. If you're looking at the World Health Organization definition, their definition is any occasion that attracts numbers of people to strain the planning and response resources of the community. So I think if you look at both FEMA and WHO, they both say the common thing. Basically, it's a activity that's not part of a daily routine that is going to be large enough to stress the resources of the community in terms of providing for the number of spectators and participants. So mass gathering issues, typically they add pressure to local emergency responders and response systems. It adds additional pressure on local emergency departments, so EDs may need to staff up in terms of having people available to take care of patients and participants. You know, part of that pressure is not just the volume, but getting their own staff in and out of the facility based on traffic and so on that may be affecting the community. And then there are additional additional potential vulnerabilities. It could be a crowd disturbance. It could be a disease outbreak. The disease outbreak would be more important for events that take that are more than a couple hours long. There could be a fire that occurs either as part of the event or that involves or occurs in the community, but the event keeps firefighters from getting to the fire. There's always the risk for a natural disaster such as a thunderstorm, a tornado, avalanche, whatever. There's a risk of a structural collapse. You can think of that collapse of the stage at the Indianapolis or the Indiana State Fair in Indianapolis a couple years ago. I mean, that's a good example. And then there's always that potential risk for a terrorist attack, particularly for high visibility events in major cities or major venues that would gather a lot of publicity for the terrorist organization if they would pull something off. So we always have to think about the potential for an act of terrorism. Characteristics of mass gatherings to be considered. The event medical personnel can be overwhelmed if there is an MCI that occurs as part of this activity. People are densely clustered, so people are close together, shoulder to shoulder, and that can affect our ability to get in and get out. There are also physical barriers that are present to getting in and out of the event that could affect our ability to get to a patient or get a patient out of the event, and that could be because of fencing or gates or location of equipment and trailers. So those are all things that have to be thought about. Another important characteristic of mass gathering events is we have to rely on communication systems to coordinate care. We can't just talk to each other across the room or walk down the hall and find somebody. Our reliance on telecommunications is intense, and sometimes even in areas, if you need to use cell phones, you can have trouble with cell phone capability simply because so many people are using cell phones in the area. And finally, characteristics of mass gatherings that we need to consider is the need to coordinate among jurisdictions. For many departments, for many EMS services, these large events stress their systems uniquely, and they have to rely on other jurisdictions to provide or assist with managing emergencies either in their town or at the event itself. More things about mass gatherings. Patients produce demands for the care you provide that may have little to do with crowd size. So you can have a relatively small crowd, but if you have bad weather move in, it can really affect our ability. Alcohol and drug use greatly exaggerates behavior and makes bad behavior worse. So if you're in a situation or if you're having an event where you tend to have a rowdy crowd to begin with, think rugby games or other intense sporting events, and you throw in alcohol and or drugs, it only aggravates those behaviors. It doesn't make people more sedate. We also have to think about water availability and availability of ability of our patients and spectators to have adequate water at site. So, if you have a 6 or 7 hour event and patients don't have enough water and they're selling water for $5 a bottle, there may be a problem with inadequate water availability for our people. Think about contaminated food. So if you have a large event that is going on for hours to days, there is a risk for food to be improperly stored or improperly maintained while being out for serving. So you have to think about what risk could come with contaminated food. Contaminated food or foodborne illnesses, depending on the type of foodborne illness, can have onset of symptoms hours after consuming food. So, certain foods that have bacterial overgrowth can have bacterial contamination resulting in toxins in the food, and those toxins can result in acute diarrheal illness within hours of consumption. So if you're at a multiple day event or a half day event and patients eat food or spectators eat food early into the course of things, you can have an outbreak of diarrheal illness a couple hours after they consume the food. We also have to think about violent spectators. Again, thinking about crowds can be rowdy, and you throw in alcohol or drugs, and then you also throw in potential rivalries. There is the potential for violence, and that violence can spread, and a simple two-person altercation can become a 30-patient or 30-participant riot with multiple victims, and you could also have innocent bystanders who get hurt. So what's going to happen? And then you also need to finally think about what's going to happen to the participants in the event, so that the stress of the competition, what may happen to some of the participants in the event, particularly larger sporting events where you have non-professionals participating. So think the bike race. If it's a hot day with poor water intake and the physical stress of participating in a long event, your participants may become your principal patient population. So something to think about. So what are our goals when we provide care at these mass gatherings? Well, I think our number one goal is to provide rapid access to the ill or injured. And the benchmark that I've seen set is cardiac arrest or care for cardiac arrest victims within 5 minutes. Well, we already are aware of that. If we have a 911 call comes in that grandma's had a cardiac arrest at home, our goal is to get there and start CPR started as soon as possible. But that goal of 5 minutes is still being used in a mass gathering situation, and we need to think about how we're going to identify a patient in arrest, how are we going to become notified of a patient in cardiac arrest, how are we going to find them, and how are we going to get the appropriate equipment there. Are there AEDs on site that spectators may be using, and so on. So one of our goals is to have ready and rapid access to those that are ill or injured. And then we need to be able to provide triage, treatment, stabilization, transport for ill and injured. Part of that transport focus is going to be on what services we provide on site, so not everybody needs to be transported off of site. At most of these mass gathering events, most patients have illnesses or injuries that are mild and can be treated on site and do not require transport to a local hospital. So we need to be able to and ready to care for minor illnesses and injuries that occur on site, and so we don't have to burden the transport services by moving or transporting patients who can be adequately treated on site with a dressing or some medications. And then we also need to focus on preserving EMS function in surrounding communities. So these events, our goal should be to staff these events and provide care at these events, so we don't need to call 911 to come in for taking care of the routine illnesses, injuries that we can expect to occur at these events. EMS in the community needs to be able to meet the needs of the community, because the communities can continue to need EMS when this mass gathering event is being held. So let's talk about types of events, and they tend to bundle them into those events that are bounded or focused, such as stadium events or in auditoriums or big arenas, versus those that are unbounded and extended, which means that there's no confines. It's generally things that are spread out, so it could be a 26-mile marathon that covers a large area, or it could be a parade, or it could be a bike race. So there's the bounded or focused events versus the unbounded. If you look at it for more detail, the bounded events tend to be in stadiums, and they're more likely to have a higher rate of patient presentation. So they call that the PPR, the patient presentation rate. Athletic events tend to have higher PPRs and events that last more than 6 hours. So if you have an event that's going on for a couple of days, you may only have 1 or 2 patients per hour, but you spread that over a period of 3 days and you have a considerable number of patients. Any event that has alcohol or drug use will result in higher patient presentation rates. Any event where patients are freely mobile, so think about general admission versus assigned seating. Any event that has unfavorable weather, and it could be extremes of hot or cold. It could be weather where it's maybe 55 degrees, but it's now rainy, and patients who come in dressed in shorts and t-shirts now going from being prepared for warm weather to actually being at risk for hypothermia. And then any event where there's inadequate food or water or both for the participants and spectators, there's more likely to be a higher patient presentation rate. It could be something as simple as patients come in because they need to be rehydrated, they have inadequate fluid intake. Those rates that those events that tend to have lower patient presentation rates are those that are unbounded events, such as marathons and parades. Many a times, patients or spectators in these events will self-triage and self-present to the local facilities. So if you have something happens with a spectator in a marathon and they have an event at mile 13, they may just self-transport to a local urgent care or hospital rather than call 911 to manage their abrasion or their ankle injury, whatever it might be. Short-term events that last less than 6 hours tend to have lower patient presentation rates simply because there's less opportunity for the participants and spectators to be exposed to an adverse event. And then any event that is assigned seating is less likely to have tends to have a lower patient presentation rate because everybody knows that their seat is seat E3 rather than they can pick any seat in the auditorium. Just look at some statistics. These are just some general statistics. If you look at the literature, the statistics can vary quite a bit, but stadium-bound events tend to have 1.25 patients per 1,000 participants or spectators. Unbound events tend to be considerably less than that at 0.3, and again, that's because there's less likely to be conflict between patients. Patients are more likely to self-present to care facilities rather than request care through 911 or EMS. If you look at all events at whole, the presentation rate is anywhere from 0.5 to 2 per 1,000 participants and spectators. Cardiac arrest rate is pretty low, so 0.01 to 0.04 per 10,000 spectators. So you almost need 1 million spectators to get to one cardiac arrest. But again, we're not going to be dealing with 1 million spectators. But if we were in New York City, where they could have 3 or 4 million spectators show up for the fireworks, you can anticipate 3 to 4 cardiac arrests are going to occur in that group of spectators. Again, things that influence the statistics have to do with the type of event and the spectator size as well as the climate. Some additional statistics, concerts tend to be big events, and the highest risk concerts tend to be rock concerts, particularly rock concerts where there may be alcohol and drugs available. So you're talking about the average rock concert has 14 patients per 1,000 spectators. So if you have 10,000 spectators at a rock event, you can expect over 100 participants or spectators requesting aid. Many of these people can be treated on site, but still there's a burden that has to be absorbed by the on-site EMS providers. Sporting events can vary from 0.3 to 1.6 patients per 1,000 spectators. Again, depends on how rowdy they are. Football games tend to be similar to rock concerts, whereas baseball games are less likely. My experience is baseball games tend to be fairly sedate. So the type of event will have some influence on your volume of spectators requiring aid. So if you plan for one of these mass gatherings, what do you need to consider? And I've kind of lumped it into, looks like about 6 or 7 different items. So we need to talk about resource needs, we need to talk about venue or location, we need to talk about communications. Communications will make or break your ability to provide care at an event. We need to always think about the environment. We need to prepare for an MCI event coming out of this gathering. We need to think about how our providers are going to be trained, and we need to think about quality management. And quality management includes how do we document encounters with spectators. So planning from a resource perspective, we need to consider the size and age of the crowd. We need to think about the event type and the environment. We need to think about the likelihood of alcohol and drug use. We need to think about how dense the crowd is. We need to think about the layout in terms of how close will everybody be packed in. We need to think about how people can get in, get out. We need to think about what resources are available for hydration and sanitation. We need to think also about how long is the event going to occur. If it's a 2-hour event versus a 2-week event, we need to think about all those things. We need to think about our human resource needs and how we're going to match those needs. We need to think about the medical care we're going to provide. We're going to think about how much or how little care are we going to provide. We need to think about how our medical providers communicate, and we need to think about how we're going to transport patients in and out of the event, or even within the event. Again, food, water, and sanitation need to be considered. Do we have enough porta-johns there? Are they going to be serviced often enough for the long-term events? We need to think about where are our patients going to go if they need to be transported off-site. And we need to think about the resources that may be in the community. So if we are in a community that has hospitals and freestanding EDs, what is the role of the freestanding ED versus the hospital? Not every patient needs to go to a hospital-based emergency department. And then we need to think about a treatment plan for our participants. Are we responsible for the medical care for participants? Are we only going to be providing care for the spectators? If so, what kind of care? And then is there a need for medical care for VIPs? So if you're at a concert and one of the musicians gets sick, or other VIPs, maybe the town mayor or the state senator who shows up at the event, are they VIPs, and are we going to treat them in a different way, or do they have different needs that we need to anticipate? From a human resources perspective, we need to think that each event is unique. We can think about what's been in years past for the same event. We can think about what the event does in other locations in other cities, but we need to think about that event in our location based on what our capabilities are. We need to think about what the ideal level of care is versus what's realistic. What would we love to do but we can't afford, versus what can we do that's in the best interest of everybody. We need to think about, are our resources going to be mobile or fixed or both? So are we going to have EMS providers that are out in the crowd? They're identified as care providers, or are we going to have simply a fixed location where participants or spectators can self-present if there's a problem? And then we also need to think about the scope of the staff of the service and the staff qualifications. So who's going to be on site? Are you going to have EMTs? Are you going to have paramedics? Are you going to have nurses? Are you going to have physicians? Or are you going to have a combination of all of the above? Those are things that need to be considered as part of the process. I think we can all agree that having an EMT on site is the basic minimum level of care. And I think we also need to agree that if you have non-independent practitioners providing care, then there needs to be a protocol. So physicians, nurse practitioners, and PAs do not need to have a protocol. They are independent practitioners and able to come up with their own plan of action to care for patients. But if we're having EMTs, if we're having paramedics on site, what are we going to use for the protocol? Are we going to use our standard protocol, or are we going to use a different protocol, or are we going to modify the existing protocol? And I think that needs to be considered, because if we are going to focus on treat but not transport, does your current protocol cover you for those events? So if a patient requires hydration therapy, can you provide that and discharge the patient back into the crowd? If you're going to observe an intoxicated patient and not transport them, at what point do you discharge them back into the crowd, and are you able to do that? And again, from a level of care perspective, we need to think about what's ideal versus what's realistic. We also need to, again, consider what we can do on site so we do not burden local EMS. If a patient requires transport off-site, our option should not include calling 911 and asking for a community transport truck, unless a certain threshold has been exceeded and we need their additional help. But I think our expectation should be that we can provide on-site services and transport based on resources that are committed to the event, and not rely on local EMS to respond to the event unless something really bad happens. We always need to think about the MCI, so at what point do we call for help? At what time do we activate our MCI protocol? And we need to, again, think about how we're going to document care. Having to do with the venue, again, are we going to have mobile units, or are we going to have a fixed on-site facility, or both? If we're going to have mobile units, are they going to be motorized with a gator or something comparable, or are they going to be on foot? We need to think about the venue and weather. So if you're talking about an enclosed auditorium, weather is generally not an issue. But if we're doing an outside event, then we need to think about what resources do we need to have to cool people in the summertime if they're overheated. What resources do we have to warm people in the wintertime or in the fall or early spring if it's an outside event and people are at risk to getting cold. We also need to think about how do we protect our patients and our spectators who we present for care from the elements. So if it's very windy, if it's rainy and wet, or if it's snowing. I think from a venue perspective, we also need to think about, should we have a sobering center? So if we have a patient or group of patients who are intoxicated. They just need to be monitored. They need to be kept safe, but eventually they should be able to sober up and either be discharged to the care of a family member or a friend or allowed to leave on their own. But that needs to be considered as part of the venue, and it needs to be staffed accordingly. We need to think about how we're going to get in and out of the venue for those providers that are in the event, as well as for outside EMS. Are we going to have avenues of ingress and egress that are protected and reserved for the people who are running the show and for care providers, or are we going to have to use the same pathways and so on that are set aside for the participants and the spectators? We need to work on that 5-minute response to significant events, particularly cardiac arrest. We need to map it out. So providers who are on site need to have some knowledge of all their avenues of ingress and egress. They need to know where the AEDs are. They need to know where the resources are so they can get in and get out. If they are sent to a certain area, they need to know how to get there. They need to know where it is. And then again, all of this needs to be shared with local EMS. So if they have to come in because something big happens, they know how to get in. They know how to get out. Communications, communication is something we need to deal with. It's really what's going to make or break us. It's commonly the big fault point of these events. And we have to be able to communicate about medical care. We have to be able to communicate with those people who are running the show. We have to be able to communicate with law enforcement and security services. And most of this is done electronically. I don't think we're going to break out the signal flags and start doing semaphore. So I think this really is one of the most vulnerable parts of our plan. It has to be redundant. I think we also have to consider interagency interoperability. So if we're going to rely on other EMS providers to assist with on-site care, do they have the same radio channels that you do? I think you also need to think about talking in clear language. Abbreviations that are apparent for one fire service or EMS provider may not be recognized or known by another. So use language that's clear and understood. All this should be tested and retested. And finally, we need to think about having somebody responsible for monitoring social media, because it's possible that something can happen in the crowd, and the first way we're going to hear about it is through social media rather than somebody calling. Additional considerations for communications is how do patients on site contact on-site providers? So if you have a spectator who goes down, how does the on-site providers know that somebody's gone down? Chances are they're going to use 911 on their cell phone, or a spectator will use 911 on a phone. So if that 911 call goes to a PSAP, does the PSAP know how to get hold of the on-site commander, the on-site EMS providers, so that the providers can go to that location? And then finally, is there an assigned channel for the on-site providers so that it's their preserved frequency and there's no rollover from other events, such as a fire that's on the other side of the county? So what communication channels have been assigned to the on-site providers? We need to think about the environment. So we need to think about the hot weather, cold weather. We need to think about, in the hot weather, is there water available? Is there shade available? Do we have a cooling center? Maybe the people don't need to have medical care, but it's a place where they can go so they can sit under a fan and get cooled off, they can hydrate, and then they can go back out and enjoy whatever the event is. In the cold weather, we need to think about, is there a place for people to come to rewarm? And we need to think about rain and snow, because rain and snow can take an event and make it a disaster. So we need to think about that. And finally, again, think about an inebriate center where the intoxicated patients can be taken for observation, possibly rehydration if they need it, and can eventually be released when they're able to ambulate on their own. Again, from the environment perspective, we need to think about the hazards and the exits and the signage. We need to think about EMS is going to get in and out. We need to think about the jurisdictional capabilities. So what are the capabilities of the EMS providers on site? What are the capabilities of the local healthcare facilities, whether it's a hospital ED, whether it's a freestanding EMS? How will we get patients and how will we triage patients to these different abilities in different locations? We may need to approach local urgent care centers and see if they're willing to take patients during their normal hours of operation, things like that. Those are things that we need to think about. And again, we need to think about mutual aid should things go south and we need help. We also, I think, need to think about, do we need to ask other mutual aid companies to assist us in providing on-site care? That's going to have to be determined by your entity or your agency as you plan, and you need to think about what your current capabilities are versus what your collective capabilities may be if you bring in other entities, other EMS providers to assist with your on-site services. We also need to think that our mass gathering event may become a mass casualty event. You need to think about, is there going to be overcrowding? Will there be inadequate crowd control? We need to think about how people will get in, whether locations will be assigned seating. We need to think about, will there be controlled access points? Sometimes those controlled access points can also become a problem in terms of people getting out. So if something bad happens, there's inadequate points of egress, and those ticketing areas and those controlled access points become pinch points that result in patients being trampled or otherwise injured. We need to have really robust fire safety and prevention in place, and we need to have some idea what we're going to do if a fire breaks out as part of whatever we have planned. We need to have our medical response pre-planned. We need to have the emergency response pre-planned. We need to know what we're going to do if things go bad. So we need to think about how we're going to interface from the internal working group, those people that are working on site. How are they going to interface with the external resources that are not part of the routine care but may need to become available if something bad happens? Event security and security management need to be involved. We need to have local fire, EMS, and law enforcement involved. If it's a big enough event, we may need to consider having the county EMA involved in the conversations so that they can monitor what's going on, and they can ramp up quickly if needed. And then we need to have the 911 call center involved, and that's not just, again, in case there's something bad happens, but what happens if a 911 call comes to the PSAP from somebody who's a spectator at this event? How do they get referred to the care center, and how do we get our on-site providers notified that there's something happening that requires care? Our goal should be that if there's an MCI, there's a seamless transfer of incident command from the incident commander on site as part of the mass gathering to the person who's going to be the incident commander for responding to this much bigger event, which is now an MCI. So those are things that I think need to be worked out in advance. Training from a perspective, it's all part of pre-planning. I think for you as an individual EMS on-site provider, need to ask questions and have a good understanding. So you need to understand the geography of the event. You need to understand where you are posted and what your responsibilities are, what your coverage area is. You need to know what resources available are on site. So if you are going to be a mobile care provider and there is a sobering center available, you need to understand and know that there's a sobering center available, and then you can then move an intoxicated patient to the center where someone else can provide the care they need so they can sober up safely. You need to have an idea of the fixed assets. So if there's going to be a care facility or two care tents in two different portions of the event, or there's going to be a fixed location that's got a transport truck, where are they located? How do you get to them? How do you get away from them? How do they bring additional resources to you? You need to have an understanding of what your scope of service is and what you are authorized to do. So if you're authorized, or if you're going to use your standard EMS protocol, you should be well trained and know what you can do. But if there's some additions to the protocol so that you can provide more treat and street, so you don't have to transport every patient, then what does that amended protocol look like, and what are you allowed to do? You need to have an idea of what the security assets are. So if there's a security force on scene, what do they look like? How are they dressed? What are they capable of doing? Is it law enforcement? Is it somebody who's basically a bouncer? What security assets are on site, and how do you interface with them? Do they recognize you and know what you're capable of doing? Do the security forces know how to access your care and your assistance if they need it? There may also be an opportunity to train the security assets in terms of what are the things to look out for, and maybe even help them learn how to do CPR if they don't know how to do CPR, because if there's a cardiac arrest or a person down, they may be the first patient contact. what is the communication plan? How do you communicate? Do you have a radio? What channel are you assigned? Things like that. And then what is your role if this becomes a mass casualty event? What do you do? What's the operational plan if this just turns south and everything goes bad? And then finally, from the quality management perspective, all care has to be documented. So if we have, and that includes refusals. So we need to have some method of documenting the care we provide. Are we going to have an electronic patient care report? Are we going to do something on paper? If we're going to do something on paper, how is it archived? Because if we have patient contact, then we have to document that. I think another thing to consider about this as part of our scope of care is, do we have over-the-counter medications, over-the-counter treatment available for patients to self-dispense and self-treat? In other words, do we put a box of unit dose Tylenol out on a table, and if somebody wants it, they can take it? Do we put out some ice packs that if somebody wants it, they can take it? They're not asking for care. It's just these are readily available treatments and medications that anybody can buy over the counter. Do they want do we do it? We put it out there. But I think if we have patient contact, then we need to document that. Can a patient refuse care? So, it all comes down to, does the patient have the capacity to make an informed decision? So those are things that we've talked about before as part of our patient refusals. Again, do we have participant self-treatment versus provision of care? In other words, do we provide things for patients or participants to self-treat, self-dispense? If they ask us a question, ask us an opinion, that's patient contact. If they ask if we have Tylenol, we have Tylenol. And if we have these medications out on the countertop or on a tabletop, what do we do? Those are things to think about. And then afterwards, when it's all done, we need to have a post-event debrief. So those are things for us to think about and plan about. What did we do right? What did we do wrong? If we're going to do this again next year, what can we do differently? So I think it's that after-action report that we need to have as part of our management process of this event. So let's get back to those first three scenarios. So we've got a rugby game. It's a lifelong rivalry between these two teams. There's 20,000 spectators. So looking at that formula of 13 or let's say 14 patients per 1,000 spectators. So we could expect 240 spectators requesting aid. We're going to throw in beer at 50 cents a glass, so it's going to become a drunken brawl. What's the risk of this event? How do we need to pre-plan? So I think we need to think that there's going to be a relatively large number of spectators who are going to seek some form of care. There's a potential for need for patients or spectators to sober up in a safe place. There's the potential for violence or fights between the spectators, since this is a long-term rivalry and we're going to stir up the pot with beer. So with all of that, there's also potential that we could have a large altercation resulting in 30, 40, 50 injured people. So we need to think about what's going to happen if something bad happens. So this has the potential to go south. It's all things that need to be considered. How about the church revival? Well, I think probably we can safely assume that if it's a church revival, there'll be a lot of teetotalers. Alcohol and drugs won't be an issue, but it's going to be in a local farm. It's at the end of a dirt road. Access will be limited. We're talking about 10,000 participants in mid-August, which is probably going to be the hottest time of the year. It's entirely likely that we're going to have an older patient population with more chronic illness, such as diabetes or CHF or coronary artery disease. And because it's going to be 3 days, there's more likely that we could have disease that could be foodborne, like maybe we have some bad chicken or bad potato salad or something that's going to cause foodborne illness. So while this event may not be high risk for violence, high risk for intoxication, we have to think about we're more likely to have patients with significant medical problems, such as COPD aggravation or uncontrolled diabetes or a hypoglycemic episode, more likely to have foodborne illness. And if we have a need for medical care and transport, it could be more difficult to get resources in and out because this is an event at the end of a dirt road. So we may not be able to get resources in and out. So we may need to pre-plan accordingly based on these factors. Finally, the last event is the Tour of the Hills bike ride. I think I had it as a 75-mile event on the first slide. Let's say it's still a 75-mile event, but it's through 3 counties. There's 1,000 riders, 30,000 spectators. So the likelihood of having spectator issues is lower because patients are more likely to pre-present or self-transport to local care facilities, particularly if they have minor events. We have 1,000 riders, so there are varying levels of skill and training, so they're more likely to have some need for medical care because of dehydration. Maybe they fall down and have an injury. So we'll have to think about where are we going to put our EMS resources during the course of the route. Are we going to have some resources available for the riders at the end of the route so that when they finish the race and now they're tired and dehydrated, we can provide rehydration resources for them? Some of these riders may need IV fluids. We don't know. So we need to think about that as well. So less likely to have alcohol and drugs. The spectators are more likely to self-present to local facilities, but with 1,000 riders spread over 75 miles, we're going to have to think about how we're going to get medical care to them because they may be the group of greatest need for our care. Plus, if you're talking about having this route, I think I said it was during Labor Day weekend. It's Labor Day weekend. Everybody's leaving the cities to get out into the country, so you may have traffic issues as well, just because of the routine traffic on Labor Day weekend that are down in the hills to try to get away from the city. All those things need to be considered as part of our pre-plan. So that's my long-winded discussion on mass gathering. I appreciate any follow-up and questions you might have. But again, thank you for participating and have a safe summer.